thanks for everyone for attending. It's really a pleasure to speak at this event again. It's great to see some old friends here and hopefully make some new friends in this field as we try to help these kids as best as we can. So let's get into my talk. This is not my research I'm presenting on today. This is a really exciting piece that that myself and Miriam and Amanda Wers have worked on in the last year. So we're looking at insights into this field in the past, present, and the future. And here we go. And as Miriam has mentioned, we had just wrapped up this special edition in the journal Frontiers in Pediatrics, looking at specifically exercise and childhood cancer. So the three of us worked pretty hard to get some submissions in this field. As you all know, it's quite a niche and small area. So it was really nice to have a topic that was dedicated specifically to childhood cancer survivors and patients. And a disclaimer, as I said, it's not my work, so I'm going to showcase all the studies that we included in this special edition, and any questions you have, if there's any grilling that you need to do, please do it to the authors. I'll direct you to them and not to me. But I'll do my best to represent the studies that we did include in the special edition. So as a brief overview of the studies, we had 2 reviews, 2 trials, randomized trials, which is great. Some observational studies, some protocols for ongoing work, and a developed model. And it was really nice that we had representation from numerous different countries in this space. Again, we have a limitation that a lot of all these countries are high-income countries, so it'd be nice to get some representation as well from other countries to be able to, I guess, get a bit more of a reflection of what is the state of pediatric oncology care in other countries and how physical activity can assist in lower and middle income countries. So a bit of insight into the past. And when I'm saying the past, I'm talking about generally reviews looking back at the literature. So I'll start with a colleague and a recent friend of mine, Maxime Carew, out in Pennsylvania. And they looked into a really emerging field in pediatrics and in adult cancers, looking at cardiotoxicity. So can exercise help to prevent or ameliorate the effects of cardiotoxic chemotherapy, which is really common for children who are receiving many of these agents. So it's problematic. And we know that a lot of these children will grow up with cardiotoxic or at least cardiovascular implications from their treatment, and cardiovascular disease is very common. We know that survivors have reduced exercise capacity. There's a lot of great work coming out of St. Jude's and other collaborators that's showing that survivors have issues with doing exercise, but still their understanding of how exercise can impact on cardiotoxicity is still limited. As we know, it is really hard to do clinical research in children in this space particularly. So the theme of this paper is coming out. Can exercise actually reduce this burden? So potentially it can reduce the impact, but can it prevent it from occurring in the first place? I think that's really the million-dollar question for now. And if it can, then should we be doing exercise from the start of treatment to prevent this from occurring? So there really is a big need in this space to do trials in this area. There are some preclinical trials, but can we do stuff straight in the clinic with children from the start of treatment, bridging together oncology and cardiology to improve patient outcomes? I think that's really important in this space. I'll just highlight here very quickly. I saw Steve Folks in the audience, some really great work that was published this year or end of last year. In a really high impact journal Circulation. This study that he did, and please direct us to Steve if you've got questions, but he did an exercise intervention for breast cancer patients during chemotherapy, and he showed that exercise actually was protective for those for developing cardiovascular complications. So it can prevent cardiotoxicity in this really remarkable study. So can the same be done in children? Theoretically, we'd like to hope so. Then we move on to another trial, this one coming out of Australia, looking at exercise interventions in brain cancer and other solid tumor survivors. Really tricky population to work with clinically, but a lot of benefit that can be had. So as we see, the trials that were included, there were 2 randomized trials and other miscellaneous types, range of sample sizes from quite small samples up to 88, which is not bad. And again, miscellaneous types of tumors. So it's really hard, I guess, to discern what the best or most effective exercise type will be with all different trial types and all different populations. But what did they find? Again, yeah, all different interventions were given, and really it probably depends on the age or the functional capacity of the population. But mostly whatever is engaging, I find to think is important. There really, again, was a range of the timing of the intervention, the duration, some really short duration, some really long, and a range of time post-treatment. But adherence was really good in all these trials. So they're supervised mostly, and that's probably the case in these populations who have probably a lot of high physical needs, but no adverse events. So really good. Exercise is safe and feasible, and some secondary outcomes, that there were some other great benefits that we see in the general population. Fitness, strength, quality of life. Those are things that, they're all really important. So it's great that exercise can be done in that population, but some limitations, study design is lacking, and these were only done in older children, so not the younger children, which again, we could be encouraging, but challenging to do research in. Now moving on to the present studies that have been new data that's been generated. It's a really nice study coming out of the US, Victoria Marchese's group, looking at targeted exercise on gross motor and neuromuscular performance in leukemia survivors. So what they did in this study, they had 10 survivors of acute lymphoblastic leukemia who had completed their treatment, and it was a progressive beaded jump rope intervention. So don't ask me again any questions about skipping. My skipping is terrible, but I used to do it a little bit. But it's a really interesting training program. These children have a lot of issues with neuropathy. It's a lot of issues with balance and stumbling over. So it's a really interesting program. It started in person and really focused and moved on to a home-based program. And they did some really nice methods where they looked at some force plates and EMG to look at muscle activation and motion capture. So it's really like time-consuming data collection, but really great data that they're able to collect as a result. In terms of the jump training intervention, it started just short jumping time with low reps, and it increased the amount of time and the amount of reps as well. And there's a range of different techniques used in the jump rope field, none of which I know. I just knew of the main original type that I know of. So there's actually a lot more to the jumping world, which is really great. And yeah, I'd be curious to learn more about the different types of jumping. But in terms of the results that they found, it was really great to see that even though small sample size, the participants were increasing their muscle activation of the lower limbs, which was the primary outcome, and which is great results, particularly those who have neuromuscular deficits because of their treatment, and with neuropathy can be quite a burden in this group. They also found that jump height was increasing, and as well as the peak joint torque at all the key joints that are involved in jumping. So this is a potentially low cost intervention that can be rolled out, like children like to jump from a young age, and it can be done in schools and homes. Yeah, really, really low cost. So it was a nice intervention. Then we go over to Miriam's group with Dominic Gazer, and they looked at, it was a randomized trial, which looked at 2 exercise groups actually in this trial. So standard care of exercise versus more resistance focused exercise with a bit more structure in terms of the resistance training program, and comparing the impact of those trials on activities of daily living and strength. So a wide age range, all the way down to 4 years old, which is great. And they aimed for 2 to 3 sessions a week, supervised or with Zoom. And what they ended up finding was about 2/3 of sessions were completed, and it ended up being about 1 session a week. Obviously, there can be challenges in doing clinical research. And they found, unsurprisingly, that the intervention group was successful in increasing their physical activity levels. So the intervention helped them probably in other facets of their physical activity, which is great. They saw that both groups improved their activities of daily living, which is good. So I guess any type of exercise that was prescribed was helpful in this situation, but only this resistance training group had significant benefits in strength. So really, I guess it comes down to what the individual goals were of, I guess, your training prescription, what you're trying to achieve, and what the goals and needs are of the patients. Then we move over to, we've got 2 St. Jude studies here. So they obviously have a really large cohort of patients where they do a lot of testing on during and after treatment, and they follow them up until, well, forever, really. They've got childhood cancer survivors who are now in their 70s. And this study by Matt Walsh was looking at the energy cost of walking in obese survivors of leukemia. So obesity is a big issue post-treatment and in the general community anyway. It's getting worse. And so what they did is they examined the associations between obesity, measured in a couple of ways, neuropathy, but also the energy cost of walking. And they measured that, which is called the physiological cost index. It's measured by looking at the difference in your heart rate max during a 6-minute walk test compared to your resting value, and divided by your 6-minute walking performance to look at, I guess, how challenging general walking is at different intensities. And so what they found was obese survivors, they had a higher physiological cost index of walking. So it was actually more challenging for them to walk compared to less obese survivors. And they also had reduced quality of life. So they concluded that this population would probably benefit from weight loss interventions first, and then focusing on other facets of health. But obviously, coming up with some weight loss interventions in this population would have a lot of other benefits for this population. And they also found that having the impaired physiological cost index associated with lower physical function. So it could be a bit of both as well. Having reduced physical function is contributing to their obesity as well. So that a bit of a tangent for the next study, which is a study from another research fellow at St. Jude, Chelsea Goodenough, and that was looking at the association between exercise capacity, P16, which is a biological marker of aging, and inflammation in survivors of childhood cancer again. So it was a really interesting study. This one's more biological, I guess. And what they found is that this biological marker of aging, P16, it inversely correlated with both fitness and body fat percentage. So it's a potential target for future interventions to mitigate the accelerated aging that we know is quite pronounced in a lot of survivors, and that frailty that can occur in that population as well. I know we're going to have a speaker about the PAC study today. So this is one study about this study. So we're moving to Norway now. This is a really neat study by Mari Brattatig, and it's looking at device measured physical activity and cardiovascular disease risk in adolescent survivors of childhood cancer. So it was a cross-sectional study. It was post-treatment, and it looked at cardiovascular risk. So numerous ways they looked at cardiovascular risk factors. VO2 peak, BMI, blood pressure, cholesterol, and compared with general reference values. And what they found was that the females didn't have any increased cardiovascular risk as an adolescent, but the males did. So they had quite pronounced VO2 differences compared to norms. And then when you combined all these risk factors, they came up with their cardiovascular disease risk score. They again had heightened risk. But they did find, sorry, excuse this, me putting in this modeling picture, but I guess the theme is that they found that 10-minute increase in vigorous intensity of physical activity associated with reduced cardiovascular risk factors. So what we can say to here to patients is something is better than nothing. 10 minutes is great. Just 10 minutes can reduce your risk. It doesn't have to be striving towards the government guidelines, which can be maybe excessive to get from 0 to 300 minutes, whatever that might be in each country. Just 10 minutes, let's start with that for now, and then we can work on it more and more over time. So just small increases can be pronounced. And looking into the future, yes, I'm in Australia and it's Friday, it's midnight. I'm in the future, but what can I tell you about the future of exercise oncology in pediatrics? There's some really neat studies coming out of Denmark, and I'd really like to highlight them. They're probably started, so I'd love to hear how they're going. But Anna Pouplier highlights this rehab study, which I'm really excited about. So it's newly diagnosed 1 to 5-year-olds in children. I don't know if this has been done at all or much at all. Obviously, it's a really challenging population. There's so much going on, very protected group, but kids need to be running around, and especially that age as a toddler, they're explorative, and it'd be great to get them moving. So this study is looking at active play, structured and home-based, and looking at the primary outcome of gross motor function at 6 months, a range of secondary outcomes. And they've structured this intervention around, I guess, different types of activities. So some activities that children can do independently, but also things that they need to be guided for. So they need assistance or they need instructions because they're in that phase of learning. So it's a combination of things that they can do and things that they can learn as well. So group-based or supervised, parents can join, and 3 times a week. It's a really nicely designed trial with lots of good outcomes that they'll be measuring at different time points and quite regularly. So it seems it's going to be a really nice study. As we know in pediatric exercise oncology, we are limited by small studies and often poor designs. So this hopefully will be a really nice addition to the literature. And again, here's just a summary of what an exercise session sort of could look like. Each session will start with ritual activities that kids are aware of and they can do by themselves, and then reinforce and repeat movements, and then start to have more challenges in their active play sessions, and then finish with things that they enjoy and set up those good behaviors for the kids. Here's some examples of things. You can see my slides later on, or you can find this in their supplementary folders if you are working with kids of this age. These are some examples of the progressions of that they will start with. But yeah, kids will develop these skills rapidly as they age from a 3 or 4 or 5-year-old. And in that same group, they also have a trial that's working with 6 to 17-year-olds. Will be 3 hospitals in Denmark, and it's looking at 6 months of neuromuscular and home-based exercise during treatment, with the primary aim looking at quadriceps strength, and secondary aims, a bunch of secondary aims, which is great. There's going to be a lot of really good outcomes. I'm really interested to know about the days hospitalized. It's a really nice clinical outcome. If we can see that exercise can help mitigate that, that could be really great for a lot of good reasons. A lot of nice time points in this randomized trial. Again, really nice study design with lots of good measurements. So looking forward to hearing about that. And in terms of the intervention, yeah, there's nice, I guess, structured exercise that they're doing. But I did want to highlight, this is in their supplementary file, a nice example of an exercise program that can be conducted in this population. And maybe it can be helpful for someone who's looking to work in this population and, you know, think about some of the different metrics you want to use or the progressions. And they use the chemotherapy periodized training program where you can make it more challenging when patient has low symptom burden and really dial back when they do have symptom burden. But instead of doing nothing, maybe you can just do something similar, something simple. And then lastly, Sarah Grimshaw from Australia had a nice program around the behavior change intervention. I'll try to wrap up because I'm going short on time here, but it's a nice framework to develop programs. And what she did is, I guess it's a nice framework if you're working with this population for the first time. And she came up with these themes of different things that you put into a program: education, goal setting, brainstorming activities, identifying barriers. These are all really important things, particularly with this population. And then coming back to these programs, resolving problems and making plans are really important components of programs, particularly during treatment. So yeah, this was just an overview. We had all different ages, all different phases of treatment. We had some less studies populations, which is great. So hopefully it's a novel addition to the literature. We want people to start exercise early. So figure A is where we want people to be doing exercise so they can develop important behaviors in childhood, go back to school more active, and have less late effects as they grow up, rather than that figure in C where they have a lot of issues and they only start exercising later, but later is better than nothing. And can we overcome the challenge of getting people active like the IPOG guidelines and promote exercise across all facets of their children's lives: hospitals, schools, communities, at home, many places that physical activity can be achieved. So with that, I'll stop talking. Thank you all for coming, and thank you for having me in my talk.